Okay, so chapter 8 is going to be somewhat of a bridge between chapters 7 and 9. Chapter 7, of course, was on the skeletal system and the bones, and chapter 9 is going to be on the muscular system. Chapter 8 is on joints or bone joints, specifically how one bone is held together with another. We will also talk about joint movements and such in the muscular system as well. So it's somewhat of that bridge to going from the skeletal system into the muscular system next chapter. So when we say a bone joint, another word that you may hear me say is articulation or articulated. For instance, when you're seeing a skeleton that is together and you see where one bone meets the other and it's one full skeleton, that is considered to be an articulated skeleton. But the bones, for instance, if they're just the bones that are not together and not pieced together, they're disarticulated. And so an articulation is also considered to be a joint. And that's going to be what allows for movement, is going to, of course, bind bones together, and it's going to allow growth. While for growth, it's going to allow for movement and allows for things to change, specifically during necessary parts of our lives, like childbirthing. And for instance, the skull that's not fused when we're born, those sutures aren't fused so that they can change shape and allow for childbirth. So there are a couple ways that we can classify joints. We can first classify them structurally, and then we can classify them as how they move and how they function. So when we talk about structural classification of joints, we are specifically talking about what helps to make up that bone joint. Like specifically what's holding it together. Are there fibrous connective tissues? Is it some type of cartilaginous or cartilage that's there? Or is it a synovial joint? And this is actually the one that is the most common. We'll spend quite a few slides talking about examples of synovial joints because those are going to be the ones that we find the most complexity in. And then we can also classify them based on how they move or how they allow for movement. The very first one, again, anytime you see the prefix or the word arthro means joint. And so synarthrotic is going to be a joint that is immovable. And if you kind of think about that, these are the ones that don't move at all, like the sutures of the skull that have fused. Amphiarthrotic is going to be those that slightly move. We'll talk about some of those. And then diarthrotic are the ones that are freely movable. Those are the ones that are going to be what you think of when you think of a joint, like the ball and socket joint of maybe the shoulder, or the ball and socket joint of the hip, maybe the hinge joint of the elbow or the knee. Those are going to be considered diarthrotic joints. And we'll talk a lot about those diarthrotic joints over the next few slides. So going from synarthrotic to diarthrotic, it increases movement. So movement increases here. Okay. So we're going to start first with our fibrous joints. And we have fibers or types of very dense connective tissue that's going to hold those joints together. And if you remember when we were talking about types of fibers, when we were going through connective tissue, one of the strongest fibers that we have is collagen. And so those are going to be extremely tough, and they're going to be found in places like what we're going to talk about the next few slides. So the very first fibrous joint is called syndesmosis. On syndesmosis, they're going to be what we call amphiarthrotic. Um, and amphiarthrotic, if y'all remember, it means that it can move, but not um, freely movable. There's a little bit of movement there. And so, an example would be between the tibia and fibula, where we can kind of twist them a little bit, but it's not freely movable like the ones that we kind of think of when we think of a joint. But it does have this, what we call interosseous membrane between the two, which again is just this connective tissue that's bridging the two together. And also will have this interosseous ligament, and a ligament is the connective tissue that binds together bone to bone. So we have ligaments and we have tendons, which is something we'll talk about later. A tendon is going to bind a bone to a muscle, and with a ligament, it binds bone to bone. Another type of fibrous joint is a suture, and this is the one that we are probably the most familiar with in the fibrous joints. This is the one that's synarthrotic, which means that it does not move at all. And we also know that our sutures are going to be those that are in the skull. For instance, we have the parietal suture, we have the coronal suture, we have the sagittal suture that separates those. Um, that separates the parietal bones, and those are going to be all the sutures of the skull. And then we have gymphosis, which I think is quite interesting. Gymphosis kind of sounds like the gums, and that's actually where we find gymphosis joints. Also fibrous, so it has that dense connective tissue, but gymphosis is going to be what anchors the tooth inside of the jawbone. And it's going to be synarthrotic because we don't want it to move. Of course, we know that as we age and as we go from toddlerhood to childhood, or even young childhood, we may lose teeth because of teeth being pushed through, or maybe the ligaments are becoming looser as we get older. Then they may come out, but as an adult, they should stay in, and that's why they're considered synarthrotic or immovable. And then we have our cartilaginous joints. Remember, this is the second type of structural classification for joints. So they are going to be made up of cartilage. Now, they could be made up of two types of cartilage. We have hyaline cartilage and we have fibrocartilage. We'll talk about examples of ones that are made up of hyaline cartilage and those that are made up of fibrocartilage. So the very first type of cartilaginous joint is synchondrosis, and it's going to be synchondrosis is synarthrotic, which means that it's immovable. And we'll find with synchondrosis, and chondrosis means that we have, anytime you see the prefix chondro, that's in reference to cartilage. And so synarthrotic, immovable, chondrosis, cartilage. And so these are going to be hyaline cartilage specifically, where we find in the thoracic cage. So going from our true ribs to the sternum, and even those that kind of fuse with some of our false ribs as well. And so that's these the white parts that you see here. Those are going to be synchondrosis joints that help to fuse the ribs with the breastbone or the manubrium. Our second type of cartilaginous joints is a symphysis. And we may have mentioned symphysis before when we were talking about the parts of the pelvic bone. If y'all remember, we have the ilium, the pubis, and the ischium. The pubis part is here, and between the two pubis bones of each hip bone, we have some cartilaginous connective tissue here. and that is going to be called the pubic symphysis. And they're going to be amphiarthrotic, which means that it can move but limited. And that is going to play a part specifically in the pubic symphysis. And I have a question here. Why is this necessary? This is going to be necessary specifically for childbirthing. And so at a certain point of pregnancy, towards the end, we, as women, start to release a hormone called relaxin. And as the hormone sounds, it starts to be released and starts to relax the ligaments here and this joint so that it can aid in childbirthing. And we also, between each vertebrae, have this disc. You all probably have heard people say that they have protruding disc, or something's wrong with their disc within or between the vertebrae, or the disc may have had some type of issues where if that happens, it could possibly pinch a nerve, because remember, our spinal cord is going through the vertebral foramen here, and that could cause pinching of nerves that are coming from the spine. And so there is, again, very limited movement so that we can move about with our spine, but very, very, very limited will be our symphysis joints. This is just another image showing our spinal cord and how it is associated with our vertebrae. We have our two vertebrae here, just kind of reviewing. We have our spinous process, they're here, and to the sides, transverse process in our bodies. And in between each vertebrae, we have our invertebral disc, which is a type of symphysis disc, or symphysis joint, I'm sorry. So we're going to move on to the other type of structural joint, and that's going to be our synovial joint. And I told you all before, or previously, that this is going to be the one where we'll spend most of the time when we're talking about the types of joints, because this is the one that you're probably the most familiar with when you're thinking about a joint. Okay, so all of these are going to be diarthrotic, which means that they are freely movable joints. So these are the ones that we find in our fingers, our wrists, and our knee, and our shoulder and elbow. These are going to be freely movable joints. And as we have talked about previously, we have at the end of our long bones articular cartilage. And remember, the articular cartilage is there to reduce friction so that when one bone meets the other, there's no friction between the two, or there's not much pain there. We also have what we call a joint capsule. Within this joint capsule, and the joint capsule is all of this. It's the fibrous portion with the synovial membrane, all that. But that's going to, again, like I said, have the fibrous layer, which is here. It's kind of white portion there. And also the synovial membrane. The synovial membrane is a membrane is a part that kind of is a barrier that lets things in and out. And so that's the synovial membrane. And inside of the synovial membrane, this blue portion, we have synovial fluid. And this is what, again, helps to cushion joints. Sometimes the synovial fluid may leak, and this is where you may have issues with water on the knee or swelling in certain joints when there are injuries. And I'll discuss that briefly in a few. So some other things that you may find in synovial joints, in addition to the fibrous layer that we have in the synovial membrane. Talked about articular cartilage that's going to be on the ends of long bones. We talked about the joint capsule already. Ligaments from bone to bone, holding them together. We talked about the synovial membrane as well. That's just the membrane out here. The synovial fluid, we mentioned this. That's the part that's within the membrane of this whole joint capsule. We also have a meniscus or menisci, and the meniscus is this area right here. It's kind of a padding of some or of sorts to help with cushion as well, especially in joints that are very complex. And then we also have bursa. We have a bursa here. We also have another bursa here, and this is actually the knee joint this picture is showing. We have a bursa here. We have a bursa right in front of or anterior to the patella. And those are fluid filled paddings. So we have the meniscus that's a padding, but we also have a fluid fill or fluid filled paddings that are called bursa to help with cushion as well. And this is just another picture of different bursa that we may have in our knee. We have what we call the suprapatellar bursa here. We have the bursa that I was just referring to in front of the knee, and other bursa that are below the knee. Again, just fluid fill paddings within the knee to help to reduce friction and to support that joint as much as necessary. Not sure if y'all have ever heard of the condition or the disorder called bursitis. Anytime you see itis on the end of the word, that just means that there's some type of inflammation. And if something becomes inflamed, it's going to be red, it's going to be swollen, pain. And so, whenever there is inflammation of the bursa, that's going to be called bursitis. And this is just showing that there may be a little bit of leaking from that bursa. And of course, the swelling and the redness and the pain will be there. And you could actually just get the fluid kind of withdrawn in a doctor's office. They could probably just take a needle and get that removed from that area. And these are all pictures of the bursa of the elbow. But we can also have leaking of the synovial fluid. Remember, we talked about how we have the synovial membrane, and within the synovial membrane, there's synovial fluid. That synovial fluid sometimes leaks out, and it's informally called water on the knee. And it will become very tight, very uncomfortable to walk. And literally, all you have to do is to go into the doctor's office, and they will withdraw the fluid from your knee. And someone asked one year, someone asked a question. Well, will the fluid come back? It could come back if it doesn't heal properly. Will we have enough fluid in our knee that is supposed to be there? Yes, we produce fluid all the time wherever it needs to go. For instance, when you give blood, you're losing fluid from your body, but as you eat and you drink, that's why they give you those things after you've given blood. Your body starts to replenish that fluid that was in the circulatory system. And so it can do the same thing and replenish the fluid that is in the synovial joints or within the synovial membrane or within the bursa. After they have healed, then you won't have this issue anymore if they heal. So we're going to go on into specific types of synovial joints. And again, these are the ones that you are probably most familiar with. The very first one is the ball and socket. And the ball and socket is probably the one that you can easily identify the location of. But we have ball and socket within the hip and shoulder. Called ball and socket because of how the shape of the bones are and how they articulate with each other. For instance, within the hip, we have the head. This is what this picture is showing, the head of the femur that articulates with the acetabulum of the pelvic bone. Or another example would be the shoulder, where the head of the humerus articulates with the glenoid cavity of the scapula. And so that's a ball. The ball part is the femur head or the humerus or the head of the humerus. And the socket part would be the acetabulum of the pelvic bone and the glenoid cavity of the scapula. The next is the condylar joint. This is very similar to ball and socket, but it's different in that it's not ball and socket. is not the shape of a sphere, but more of an oval. So it's the same exact concept where you have one thing that is projected out, another thing that is somewhat of a cavity, and an elliptical cavity in this case. And it fits in very similar to the ball and socket, but the difference between the two is the shape of the ends. So it's not a ball, but more of an oval. It's not a spherical head or a spherical end of one bone, but it's the oval shape of one bone that fits into the cavity that is more of an elliptical cavity of the other. And we find these types of joints between our metacarpals and our phalanges. So, metacarpals of our hands here and our phalanges. This is where you'll find condylar joints. Next, our plane joints. Also, sometimes you may hear called gliding joint or sliding joint because they somewhat kind of slide back and forth, but they're not sliding back and forth so much so that they just slide past each other, but they slide enough to kind of allow for a bit of movement. And of course, we have ligaments that are going to hold them together, so they're not just, like I said, sliding past each other and the wrist is just falling off of the body, but we do have ligaments that are there to hold them so they can slide as much as they need to. So we find this in our wrists and our ankles as well. So our carpals and our tarsals. Hinge joint. Now, hinge joint should sound familiar. When you think about the word hinge, I think about, not sure about you, but I think about a door hinge. And these joints are going to be moving the exact same as a door hinge, okay? And so these are going to be found in places like our elbow and our knee. And we also have our phalanges that have more of a hinge joint. And this is what it kind of looks like, where one is kind of cupped around the other. And if we're looking at the elbow joint, we have the ulna, this trochlear notch of the ulna is going to articulate with the distal end of the humerus. Now we have our pivot joint. Whenever you think about pivot, for instance, I kind of think about basketball. When a person is pivoting, they're pivoting around this one stationary foot, or maybe even pivoting or rotating on a central axis. And so this only allows for rotation. And this is going to be found between the atlas and the axis. Hopefully we remember what those two are. So the axis and the atlas are the first two cervical vertebrae. And if you remember, we have a structure on the axis specifically that is called the dens. And it's the kind of sharp portion that kind of sticks upward. And there's an opening of the atlas that it kind of sits around and allows for rotation of our neck. That's how we're able to shake our head now. And then we have our saddle joint. Okay, as Mississippians, I'm sure you all have seen a saddle a time or two. And so it's basically kind of designed the same way as a saddle and how it kind of cups over whatever it's on. And so one or both bones are going to have this concave and convex surfaces where it kind of sinks in and also have a part that's kind of projected outwards. And we'll find a saddle joint between the thumb and the carpal of the thumb that's connected to that. So the metacarpal of the thumb and the carpal that is attached to. That's where we'll find saddle joints. Okay, a little bit more as far as types of joint movements. Very important part to make sure you know. And as of right now, it's really just me saying them, and we may have a chance to kind of demonstrate them a little bit more in class. But it's this is something that you just need to kind of spend time with. And because right now it's literally just kind of going over words and looking at the pictures as we go through them. But before we go to specific types of joint movements, there are a couple different terms, origin and insertion, that we'll talk about. And these terms will come up again in the muscular system, but the fixed end of a skeletal muscle, or where it kind of starts, is called the origin. So, for instance, the biceps of the arm. Not sure if y'all know what that is, but it's on the, if you're standing in the anatomical position, it's on the anterior side of the body, of the humerus. It originates, or the origin is at the head of the humerus. It's called a bicep because it actually has two origins, and then it inserts a little bit lower towards the forearm area. And so that's going to be the part that's more movable. So, for instance, if we were to flex our biceps, then the part that moves will be the insertion moving closer to the origin, and that is what causes the muscle to get shorter. So that's what I was referring to, this bullet here. When a muscle contracts, or when we flex or extend, depending on when we flex the muscle or when we contract a muscle, it's going to cause the insertion to be pulled towards the origin, and the muscle, of course, will get shorter. And so this is the example that I was referring to with the biceps originating. The origin is here. It inserts at the radius, and as we flex, then this part is actually pulled towards the origin, and so that's why the bicep will get shorter when we flex that muscle or when that muscle contracts. The other example is the gastrocnemius of the leg, which is informally called your calf. The origin is here with the femur and is inserted by the on the calcaneus, which is one of the tarsals of the foot. And so when this muscle is flexed, then the insertion is pulled upward towards the origin. This muscle shortens, and we'll see the contraction of that muscle. So some other types, or joint movements. These are types of joint movements. Again, these are ones that if you kind of see the picture here, it may make sense. We'll kind of go over these a little bit more in class as well, so that you can just see what these joint movements look like. So the very first one is abduction and adduction. That's this first picture. And there are ways that I kind of use to remember some of these. Some of them are ones that you may have used many times just informally in your everyday life, so they may be a lot easier to remember. But the first two, abduction and adduction. Abduction is taking a limb away from the midline. So that's taking the leg in this direction. You can also abduct your arm. And then we have adduction. Adduction is bringing it back towards the midline. Someone shared with me in another class that they remembered this as adduction is adding the limb back towards the midline. So bringing it back towards the mid is adduction. Then we have flexion and extension. Flex means that we are increasing. Extension means that we are increasing the angle between two bones. And we can flex and extend the leg, we can flex and extend the arm. But extension, we're increasing the angle between two bones. Whereas flexion, if you notice here, we are decreasing the angle between two bones. And it could become hyperextended. You all probably have heard of someone saying they've hyperextended some joint or some muscle when they are trying to work out, or maybe even playing a sport. They could possibly hyperextend. And then we have lateral flexion. Lateral is one of those terms that we talked about towards the beginning of A&P 1. Lateral means side. Flexion, again, we are decreasing the angle. And so we could flex in this direction, but this is, in this case, lateral flexion. And then we have dorsiflexion and plantar flexion. These two are in reference to the foot. Plantar should sound familiar. That's in reference to the foot. And so dorsiflexion is going to be bringing the foot closer to the tibia. Plantar flexion is more of a pointed, like a ballerina type of flexion. Circumduction and rotation, these two are oftentimes confused with each other. Circumduction is if, and you could do this with your arm, you could do this with your leg, you could do this with your head. Circumduction is, when I hear circumduction, I think of circumference. And when you think of circumference, that's the area of a circle. I think that's the definition. I'm not really a math teacher, but I know it has something to do with the circle. But circumduction is when we're moving a limb in a circle. So if you were to take your arm right now, stretch it straight out, and you were to move it in a circle, that's going to be circumduction. But if you were to take it straight out and just rotate it, not move the tip of your finger, it's still pointing, your fingers are still pointing in the same direction, but you're just kind of rotating it around a central axis, then that will be rotation. Another example for rotation is just shaking your head no. Okay, that's going to be rotation. That's rotation. But if you're trying to stretch your neck muscles, you may line your head all the way around. That's going to be more of circumduction, where it's going in a circle. The tip of the head is going in a circle, kind of making a circle in the air. And then we have medial rotation and lateral rotation. Medial, again, is middle. Lateral is towards the side. Okay? Still rotating, but lateral towards the side, medial towards the middle. Supination and pronation, all about the hand. Supination is where we are putting our hand in the anatomical position, facing forward. Pronation is facing the palm of the hand backwards. Next, inversion and eversion, all about the foot. We're inverting the foot towards the midline. That's inversion. In means inside. E means out. So eversion, turn it towards the side of the body, or the lateral side of the body, or lateral region of the body. Protraction and retraction, you can show this easily with the chin. If protraction means, pro means to before or head, so we're pushing our chin forward. Retraction means to bring it back. If you want to retract a statement, you bring it back. All right, you try to take that statement back. And so to retract your chin, you're bringing it back. To elevate and to depress. Elevate means to bring higher. Depress means to go lower. So we can elevate our shoulders and we can depress our shoulders. Elevation means they're going upward. Depression means that they're being pushed downward. If you've ever done any exercising, you've probably been told to elevate and depress your shoulders during a warm-up. And then we have types of synovial joints. These are some other examples of synovial joints. Some of those are a little bit more larger and more complex. Again, synovial joints are those that are diarthrotic, which means that they are freely movable. And so the four that we're going to talk about, the next 2 slides, will be our shoulder joint, elbow, hip, and the knee. And we'll talk about some of the ligaments that are found in each of these. So the first is our shoulder joint. First, I want to say, we know that this is the ball and socket because we've already mentioned it. But for each of these, know what bones help to make them up. Like, for instance, the shoulder joint is going to be the head of the humerus and the glenoid cavity of the scapula. But I also want you to know what ligaments help to hold this joint together. And it may seem to be a lot right now to kind of think about, oh my gosh, there are so many ligaments, and how will I know which ligaments are holding which joint together? But it's not going to be that difficult because the ligaments are usually named for the bones or the features of those bones that are being held together. For instance, we have the glenoid ligament or labrum. That's going to be the ligament that's holding this together, and it is going to be what is, remember, glenoid cavity is named for our the cavity of the scapula, and so that's what this ligament is kind of named after. So if you were to see this as a question, if you were asked this, where is the glenoid cavity located, hopefully you remember that the glenoid cavity, or the glenoid cavity is on the scapula, so this is probably going to be in the shoulder joint. And of course, this allows for rotation and circumduction, which is what we were just referring to in the last few slides. Some other ligaments, the coracohumeral ligament. Humeral, lets you know that it's near the humerus. Glenohumerus, because of the gleno cavity and the humerus. And the transverse humeral ligament. So all of these tell you that it has something to do with the humerus. So do know which ligaments are found where. We have our transverse ligament here. We have our coracal ligament there. Again, all these ligaments are going to be named for our the bones that are around, even the features of those bones. Next is our elbow joint. We have a couple different things that are happening within the elbow joint. First is our hinge joint between the humerus, or the trochlea of the humerus, and the trochlear notch, or that U-shaped hook of the ulna. And of course, this allows for flexion and extension. And we also have a bit of a gliding joint between the capitulum of the humerus, which is also in this area, and the head of the radius. So they are kind of interacting or articulating in this region. And so I'm going to show you the ligaments that help to reinforce this joint. And again, like I said, they look a bit complex if you're just to look at the name, but if you kind of think about what bones are there, you should be able to identify that this is going to be part of the elbow joint. For instance, we have our radial collateral ligament. Radial means the radius, and then collateral, those are going to be ones that are towards the side, to our radial collateral ligament. And then our ulna collateral ligament on the ulna towards the side, and annular ligament as well. It's going to be one that kind of anchors all the way around both of those, kind of hold them together. Next is going to be our hip joints, also ball and socket, and we've mentioned what ball and the socket of which bones. It's the femur and the acetabulum of our hip bones. And one of the ligaments is the acetabular ligament or labrum that's holding that together. And it is going to have a lot of movement, but not as much as the shoulder, because it is a little bit more reinforced than the shoulder joint is. So some of the ligaments that we have in the hip: iliofemoral, very complex looking ligament name. Ilio is for ilium. Remember the ilium ischium pubis? So this is the ilium, so it stems from the ilium. Femoral, and it goes down to the femur. Strongest ligament in the body, which is quite interesting. Pubofemoral ligament, remember pubis, so you can probably guess where it's going to be. And then we have the femoral ligament, which is here. Remember, ischium, pubis, ilium. It's just another look at those ligaments of the hip. Whereas the iliofemoral ligament is the strongest ligament in the body. And that's this one right here. We have this extra little slide here about the clinical application of joint replacements. And you all may have had maybe a joint replacement or knee replacement is what we sometimes call, where they literally are replacing the joint, and it may be the cartilage of the joint with some type of synthetic material that's going to do what's supposed to have been done when those joints, because those joints are damaged. And it could be from just normal wear and tear. It could be from arthritis. And so they go in and they replace those joints with maybe steel and titanium or silicone to help to reduce those joints, whatever is worn down. And our knee joint. Our knee joint is going to be the largest and the most complex joint because of how much the bursa that we have, the meniscus that we have. We even have fat deposits that are within the knee. All of the above to help cushion this very complex joint. And 3 bones are going to be involved. We have the femur, the tibia, and the patella. Many things that are going to help to cushion those bones and the articulations of those bones. So lots and lots and lots of ligaments here. So we know that we have a hinge joint, we have flexion and extension, all of that. We also have a patellar ligament. Again, this is one that should be easily identified that it's in the knee joint. Oblique means that it's slanted. Popliteal, hopefully we remember that is the back of the knee ligament. And that's going to be the oblique popliteal ligament here. Oblique means that it's slanted. Popliteal means the back of the knee. Cruciate popliteal ligament also towards the back of the knee here. Tibial medial collateral ligament. So it's the tibial, so it's towards the tibia. Medial means that it's towards the middle, but lateral means it's towards the side. So side, middle, the tibial collateral ligament is towards the side. Fibular collateral ligament is going to be on the opposite side. Then we have something called the anterior cruciate ligament and the posterior cruciate ligament. Anterior is towards the front, posterior is towards the back, and you can see the posterior cruciate ligament right in here, and you see the anterior right in here. These are formally known as the ACL and PCL. So when people say that they've torn their ACL, they're torn their anterior cruciate ligament. And oftentimes these are going to be torn because they help the knee from either going forward or backwards, or the femur from sliding past the tibia or being pushed backwards. And the anterior one is the one that's most often being torn because if something happens, the femur is usually going to be the one that's pushed forward, and the anterior one is the one that's going to be damaged. So and I added this extra slide. I don't know if this one is in your notes or not, but this just kind of breaks down collateral ligaments from cruciate ligaments. Collateral is going to be side ligaments to control the sideways motion of the knee. So that's the ligaments that are here, the fibular collateral ligament and the tibial collateral ligament. And then those cruciate ligaments are the ones that are in the knee. That's going to be our ACL and our PCL that are towards the inside. that control the back and forth of motion of the knee, and that's these here. So we want to make sure that it's not going in this direction, and we want to make sure that it's not going backwards and forwards. It's just another image showing our ACL here, our PCLs towards the back side, and our lateral collateral ligament, and our other medial tibial ligament there. We have another clinical application, just some of the joint disorders. I've already talked about bursitis, kind of mentioned arthritis as being one of those things that could possibly influence the wear and tear or the need of joint replacements. And this is going to be this where you have swelling, very painful issue within the joints. Can happen anywhere to any person, any body. You can have a couple different causes. One that is the most common type is osteoarthritis. That's just from old age or time, normal wear and tear. And then we also have rheumatoid arthritis, which is an autoimmune disorder. And if y'all know anything about autoimmune disorders, it's where the body kind of fight against itself. It's supposed to recognize those things that are not self and attack it. But with autoimmune disorders, they attack self, or our cells that are supposed to attack those things that are foreign start to attack self and cause issues. So another example of an autoimmune disorder would be lupus. And as far as our lifespan changes, as we get older, and I've mentioned this before, we have normal wear and tear of our joints, and it could be where the cartilage is being worn down. It could be where the ligaments are losing elasticity. It could be where the synovial fluid is starting to leak, or those joints start to lose as much function as they once had. We lose our flexibility that we once had, and joints become very, very stiff, and that's going to be one of those that we start to feel a lot earlier than we like, and I'm a witness to that. We start to feel the stiffness of those joints, and that lets us know that we have started to age just a bit. And this is the end of chapter 8.